Dr. Mills. I'm one of the urologists here. Today we're going to talk about catheter care, catheter insertion, catheter irrigations, and basically everything that you'll need to know to manage Foley catheters on patients on the floor. When you do insert a catheter, you're supposed to insert the catheter all the way up to the hub of the catheter. Okay. Now, that's mainly important for men, just because the men have a longer urethra and they have the prostate here. If you start putting this catheter in, some people start putting the catheter in, as soon as they see a little urine come out, they blow the balloon up. Well, that's not an accurate way, because what happens is many times when you're putting a catheter in, a man will actually start urinating and force some urine to come through the catheter. But if that catheter is only this far in and the urine starts coming out, you should not blow that catheter up, because that balloon is sitting somewhere here in the urethra. You have to put this catheter all the way up to the end of the urethra in a man to make sure that it's in the proper position. So again, do not put the catheter in part of the way and blow the balloon up. The catheter should go all the way in, all the way up to this hub. In many instances, patients are going to say, well, that's uncomfortable. And the answer is yes, it is uncomfortable. It's uncomfortable to have any catheter inserted. But just when you start putting it in, and if a man says that's uncomfortable and the catheter is going in easily, you have to continue advancing the catheter all the way up to this bifurcation of the balloon and the drainage port right here. This is your typical catheter kit that you get on the floor. It has a catheter that is pre-connected to a bag, and which is fine to use. Number one is that it's a closed system because this is already sealed. So this catheter is fine for using for female patients. Okay, it's simple to insert. Usually they work well, and the reason it's fine for females and not so good for males is because the tip is straight. Okay, this is just a regular Foley catheter, a straight tip catheter. Okay, as opposed to this type of catheter, which is called a coude catheter. As you can see, it has a curved tip to it, to where this tip is pointed upwards. And this is the orientation when you insert this type of catheter. The tip is always pointed up. You do not point it down like this, because it won't go into the prostate. So this is a catheter that should always be used for male patients. When a male patient requires a Foley catheter, you should never use one of these kits. Okay? Basically, the reason for that is, if you look at this drawing right here, assume this is a man that's been cut in half. And this is what you're looking at. This is the bladder, this is the prostate, this is the urethra right here. Here's the end of the penis. So basically, you can see how the prostate is configured. The prostate is not just a straight line. The prostate has a hump that goes up like this. Some men, it's even more prominent, and it's called a median lobe. Sometimes this portion grows well into the bladder. So you can see, if you were to use a plain catheter, just a straight catheter, when you put this in, it's going to end up just hitting in this area, and it's not going to go up into the bladder. Many times we see where people put these in, the catheter stops right here, the nurse goes ahead and blows the catheter up, and it gets blown up in the prostate, blown up into the urethra tube, and that causes the patient extreme amount of pain. We'll get called when they say the patient's having a lot of pain, there's blood coming around the catheter, and that's because usually the catheter is not in the right location. So as you can see, with this coude type catheter, with this tip that's curved up, when you insert it, it naturally wants to go up this curve right here. You can see it's made to naturally go up into an enlarged prostate, into the bladder. That's why it's always important on men to use a coude catheter. The tip always goes up. You can always remember it too, because the stem. If you look at the balloon port, again, that's all lined up. The balloon port and the tip of the catheter are in the same orientation. Other types of catheters, many times when people have surgery, especially from urological procedures, they'll come out with what's called a three-way Foley catheter. This is a three-way Foley catheter. Essentially, it has a port in the middle where the urine drains. This is what's connected to the drainage bag. This other port right here, this is for the irrigation fluid. This is where the tubing connects into this port right here. It circulates water through the catheter and then comes back out this main drainage port. The reason for that is it prevents blood clots from occurring. It is to keep blood clots from forming in the bladder. If you keep blood diluted, it cannot clot. Many times we see on the floor what happens, people get busy, they get emergencies get called. What happens, this fluid runs out and it doesn't take it but 15 to 20 minutes before a blood clot forms in the bladder and then you can't get it out, okay? So this is the setup. And this is the drainage port, this is the irrigation port, and this is the balloon port, okay? When we talk about irrigating a catheter, this is very important. Many instances we get called and the person says they're irrigating the catheter, and what they're actually doing is they're putting fluid through this port right here, which is where you aspirate out to get a sterile sample. That is not how you irrigate a catheter. If someone calls you and says their catheter's not draining, they think they've got a blood clot in there, the first thing that you do is you come over here and you turn off this irrigation fluid. Turn it off up here at the bottom, at the bags, or you can turn it off on the thumb control port. Most of the time I turn it off in both positions, because if you don't, fluid will come pouring out of here. What you do when you get called, the first thing you do is you're going to come in, turn the water off. You're then going to disconnect the Foley bag from it. Okay? Here are the trays that you have on the floor. You have these irrigation trays that are present, which has a sterile container, has a bottle for your sterile water, and it has a syringe, a catheter tip syringe. A catheter tip syringe is, again, because it fits into the catheter. It's tapered. Okay? The first thing that you do is when you go in there, some people will come in and they'll load this thing up with water, and then a person's already distended, their bladder's already full, they can't pee already, and they go and start shooting more water in there. You do not do that. What you do, as soon as you do it, you disconnect the Foley bag, you put the syringe in empty, put it in the port, and you try to aspirate back. Because many times there's a clot on the end of the catheter that's keeping it from draining. A lot of times if you just pull back, you'll get a blood clot or several blood clots back, and then all of a sudden the urine will start flowing free. So the first thing that you do is you go ahead and you just put an empty syringe, connect it to it, and pull back. All right? If that doesn't work, the next step is you can take a small amount of fluid, about 20 cc's, push it in here, and flush it, and then pull back. But you do not want to start pushing a lot of different syringes. If you keep putting 60 cc's and another 60 cc's in there, all it is doing is causing that patient's bladder to become more distended. So if you put a small amount of fluid in and then pull back, aspirate back, and you don't get anything out, then you need to call one of the urologists that's on call. So that's the key to that right there. The key is don't let this fluid run out in the first place. Okay? You can tell it has a drip chamber right here. So you can actually control that. You open these up, and then by this thumb control, you can control how fast the fluid runs through here. The important thing is there's no set rules. Basically, you run this at a rate enough to keep that urine free of clots. You want to keep it a light pink or a light cranberry. You want to be able to see through this tubing. So again, there is nothing that says it has to run at this rate or another rate. It's all dictated by how the urine looks. A urethral stricture is a narrowing of the urethra tube. So basically you have scar tissue here or anywhere along the urethra. Some people have had their prostates trimmed out or removed in the past, and sometimes they have a stricture right where the prostate used to be. In that instance, sometimes catheters cannot be inserted. Okay? Routinely, on a man that hasn't had any previous surgery and has no history of a stricture disease, when you start talking about what size of catheters to use, you should basically use a 16 French or an 18 French Coude catheter. And again, the Coude catheter is the one that has the curved tip, because that's going to allow the catheter to go in an enlarged prostate. In some instances, if a man gives a history of having had a urethral stricture or having a real narrow urethra where he's had problems, then that's the indication that you could go down and use a smaller size catheter, such as a 14 French or a 12 French catheter. But that's going to be very few instances, because the majority of patients are not going to have that history. The majority of patients that get admitted to this hospital have an enlarged prostate and don't have a history of previous surgery or have a history of having this stricture disease. In many instances, if a small catheter doesn't go in, that's when you have to call us to be able to come in and be able to navigate something through these narrowed areas, and then we subsequently have to dilate the urethra. But again, on the routine patients, you should not use 14 French catheters or 12 French catheters. The smallest you should ever use is a 16 French coude. And in elderly men who have larger prostates, in many instances you use an 18 French because it's a little stiffer and it will be easier for it to go through the enlarged prostate into the bladder. We're going to talk about another issue also, and it's using this stat-lock device. As you'll see, when we have patients that come from surgery, most of them do not have this. They have the catheter is taped, and especially when they've had a urologic procedure, because in many instances the catheter is taped because it's pulling down on the prostate to keep from postoperative bleeding. Now that's just specific to urological procedures. On regular patients on the floor who haven't had a recent surgery, when you use a stat lock, the biggest problem that we see is that this device is placed too far down on the leg. When you place it too far down on the leg, what happens is when the catheter becomes secured to this, anytime the patient moves his leg, it then pulls the catheter against the prostate gland, and what it does then is it causes bleeding and it causes pain. So when you use a stat lock device, you have to make sure you put it high enough up in the groin area to where when the patient moves, that catheter still has some slack in it. You do not want this catheter being in and being under tension, okay? So therefore, you have to make sure that there's plenty of redundancy in the catheter when you connect it to the stat lock. So you have to assume the patient's going to be up walking around and ambulating, and therefore you don't want him every time he takes a step to where it's going to pull on the prostate and become uncomfortable. Therefore, it leads more trauma to the prostate, more infections, more bleeding. So again, be very cognizant of where you place this stat lock device to where it has plenty of slack in the catheter once it's inserted.